evening.
Very
Yes,
good
sir.
evening, Soumya. How are you?
Yes, sir, I am fine, sir. Okay.
So, by it's all because of my love for West Bengal Orthopedic Association that I consented, okay, I will manage it somehow. And it's indeed always a pleasure to be among you all. And especially when I see the younger people, I really get thrilled on it. Well, I think what I'm going to present today is basically meant for youngsters who are appearing for examination and put forward a checklist for them so that they could remember the points, the way to go, whether whether they find it positive or negative, whatever it is. So with these hints that you have to examine each and every part in your checklist so that you do not miss. Hence, you raise an objective data. Based on your objective data, and as you have already got a subjective data with you, with a history, then you are going to do a interpretation of that. So the examination of a hip is another important point of view is that this is the case that you are going to get as a long case most of the time these days. Of course, another is spine, but most of the time when you go around, when we find the cross section in the country, it's a hip which always comes forward. So with these words, I think I'll start sharing my screen with you. Just hold a minute. Yes. And this is share. This is here. And I share. Is it all right? I'm sharing. Is it visible to you all?
Yes, sir. All
Yes,
right.
sir. Yes, sir.
Go to the presentation mode, sir. Go to the presentation
Slideshow.
mode.
Okay, slideshow. Okay.
Slideshow.
Okay.
Yes,
Is it all right?
perfect.
Yes, it's
Perfect, sir.
it's all
Perfect.
right, sir.
It is
Okay,
absolutely
fine.
okay, sir. It is audible and visible. Please continue, sir.
Fine. So, as I at the very outset, I said that you have to be very, very presentable in your examination, and you have to have certain etiquettes when you are examining your patient, because most of the time you will be given a chit that you examine this patient and examine the hip. So what you do when you go by the bedside of the patient, you introduce yourself and say that, hello, my name is so and so, in the proper language which your patient can understand. And then you take a consent from the patient for examination, because you must understand that examiner is watching you. He's around, the team is around, and they're watching you, what you are doing. And also very important for national board student as well as and the university students as well, that we introduce ourselves and take the consent of our patient for examination. So the at the very outset, you will have to expose your patient, because you have taken a consent. You will have to explain to him, and for examination of the hip, you must expose the part completely, right from chest downwards. And it's very important that if it is a female patient, you must have a female attendant and a female nurse with you who should be by your side when you are examining a female patient. And you must respect the decency in every mode and have a closed environment. You'll have to respect the dignity of your patient. That's very important. And a proper exposure of the part of the pelvic region can be done either by using a T bandage in a young people, or giving them a langot or a panties. the best thing that my suggestion would be that you carry at least two free size two panties. That means one for the adults and another for the children. So that you can gift a new panty to your patient and patient will feel so pleased. So a sequence of examination is important to remember and to have your checklist. That means if a patient who is walking, who can walk, you start with walking, standing, sitting, squatting, cross-leg sitting, and then you make them lying down in supine and prone position. If you remember this sequence, you are not going to miss the observations that you make in your patient. As you are examining your patient in a standing position, the first thing that you look for is the gait. So whether the gait is an assisted gait or unassisted gait. If it is assisted gait, then you must qualify that whether he uses a stick, crutch, or any orthosis, or whether he is supporting himself on one limb or both the limbs. And basically, you get three types of gait in these patients that are given to you most of the time. You have an antalgic gait, a short limb gait, or a Trendelenburg gait, and as well the stiff hip gait. So you should be able to distinguish in these gaits, which is important. And high stepping gait, of course, you do get when you have a neurological involvement of or dropping of the ankle, which is another aspect with it. So sometimes you can have a complex gait, the limb could be short as well as it could be lurching on one side. So you must be able to distinguish, and in such cases where you have complex gait, where you have involvement of two components together, then you should be able to explain that this fellow has a short limb gait as well as he lurches and has a Trendelenburg gait. So with this, we go on to, as the patient is standing, so you look at his posture right from the front, look at the position of the head, the level of the shoulder, both the shoulder, whether the shoulder is drooping on one side or they are leveled. What is the level of anterior superior iliac spine, the level of patella and medial malleolus. The bilateral foot, whether it is plantigrade or not, and whether the direction of the patella looks to be rotated on one or the other side, and muscle wasting. You see, there are certain points that you must look into standing, because quite a number of these points you are going to again look when you are examining your patient in a lying down position, because these points can change. So when you look from front, you must look whether the patient is really bearing both the feet on the ground with equal weight. Go to the lateral profile, which will give you an idea whether the patient has any flexion at the hip or the knee. And always compare from the contralateral side. And whether the fellow has got lumbar lordosis. Go to the back of the patient, and then you can look at the curvature of the spine, whether it is, which side is the convexity. So you define the curvature of the spine with the convexity towards the right or towards the left, and the symmetry of the gluteal fold. So while this diagram tells you how you look at the various points from the front, from the lateral profile, and from the back. While your patient is standing, you also should be able to do a Trendelenburg test so that you can ascertain the abductor mechanism. As you know that the abductor mechanism, the femoral head forms a fulcrum, while the neck has a lever arm, and the abductor muscles give a power to it. So you must be able to demonstrate whether the Trendelenburg test is positive or not. So but don't comment on it, keep it in your note, keep it on your note, and when you have fully examined your patient, then tell it towards the end. So if you look at this picture, it tells you that in the normal stage, when you are bearing weight on the normal limb, the opposite pelvis gets lifted up. That is what it shows, that it gets lifted up. And where is it positive? Then when you bear weight on the abnormal limb, then the opposite hip goes down. That is what is a positive. So you look at the positive Trendelenburg test, look at the gluteal fold and the drooping of the pelvis on the opposite side. After that, for a functional assessment, which is very important in our kind of setup, where most of our patients have floor activities to perform. So ask your patient if he can sit on a chair, and then you can look at the level of both ASIS and whether he can squat or whether he can sit cross-legged. Squatting position, you must be able to carefully evaluate it, because many of your patients, you will find he will say, I can squat, but can he squat in the right position? Many a times they will put their knee on the ground, and as the hip doesn't move beyond a certain arc, so the patient are able to still manage, and they say, okay, I can sit, I can squat. But in squatting position, you will be able to assess what is the hip restricted in its flexion, and that is most important. And similarly, whether he can sit cross-legged or not. Now, then you ask your patient to lie on a bed in a supine position. That means now you have to make sure that when you are making him lie in a supine position, your underlying bed that you have should be absolutely straight. If you have a sagging mattress and you don't have a hard surface, then you may miss certain of the deformity. So while inspecting, you should be able to look at the attitude of the limb, whether the fellow has got lumbar lordosis, what is the level of anterior iliac spine, are there any swelling, scar, or sinuses? Looking at the scar and sinuses is of extremely important, because the scars or sinuses which are puckered, they are a telltale story for a pyogenic infection. But if you have a scar which is papery thin, then this gives you an indication that this must have been following a healing of a granulomatous infection. So these scars have a great assessment that you need to make, whether the scar is a surgical scar or otherwise. Level of patella and level of medial malleolus. So the attitude of the limb, look at the lumbar lordosis, which are very important, and the level of these bony points, medial malleolus, and the patella. You come on to the palpation. Now, when you are palpating your patient, you should be able to palpate the skin right from the periphery to the center. That is what we call as a temperature gradient. That means the peripheral area is much cooler, and as you go above, as you go proximally, you will find the temperature starts becoming a little warmer and warmer. So that gives you a lot of indication whether it is a infection or whether it is any vascular impediment. Now, tenderness at the base of Scarpa's triangle. You should feel a Scarpa's triangle, should know where the Scarpa's triangle is, and then start eliciting if there is any tenderness. Level of ASIS. The levels of ASIS should be marked right in a supine position, and you should be able to tell them that I've marked these in a supine position when the patient is lying down. Compare bilateral iliac crest, which is very important. You see, comparing the girth of the iliac crest bilaterally is of great importance, because this can give you a lot of information. Because a problem which has started possibly well in young life can tell you whether the iliac crest is relatively hypoplastic or it is normal on either side, or if there is an infective process, it might appear to be thickened. So this is an important parameter which you need to palpate when you are onto your system of palpation. So compare them from the other side. Vascular sign of Narad gives you a great information, and then you check for muscle spasm, which is an important aspect for your analysis. Digital blind, we don't call it digital. I think it's wrongly written here, but what can do is, with the digits, with your digits, you can feel whether the greater trochanter is comparable in its proximal point. That means by palpating the anterior spherical spine and keeping with your thumb, and with the middle finger you palpate the what you call your tip of the greater trochanter, and then you can move it up and down and find out whether they are bilaterally symmetrical or there is any discrepancy. It gives you an idea before you start you start drawing your triangles. Greater trochanter, whether it is proximally migrated or it is tender on pressure, and what is the surface line. So the very important thing that you need to note down is the girth, anteroposterior broadening, what we call as the anteroposterior girth of the greater trochanter, and the surface is regular or irregular. These two aspects are very important, and whether it is tender or not. And proximal migration, you can ascertain by various tests. So, so your level of ASIS is important, because you have to look at the level of the ASIS by bringing your eye level at the same level as the anterior spherical spine is. That means you have to bend down, you have to sit down, and then make a parallax with both the ASIS. So it will give you an idea of any fixed deformities. That means whether it is raised up or it is down, depending on whether it is an adductor deformity or an abduction deformity, or there is no deformity. So are there any fixed deformity? This is the time when you should be able to identify if there are any fixed deformities. And the flexion deformity, as you are very well aware about it, can be tested by a Thomas test, in which you know that the opposite limb has to be flexed, and by keeping your hand under the lumbar spine. And then you find out whether the affected limb flexes to what degree, and it cannot be straightened out. So then the arc of motion, you should be able to describe the arc of motion in your hip joint, whether it is active, whether it is assisted, or you have to do a passive movement. So it's important. So whether this is associated with pain, spasm of crepitus. So arc of motion need to be defined in flexion, adduction, and abduction, and rotations. With these qualifying remarks, whether it is active, assisted, passive, or it is associated with pain, spasm, or crepitus. And then what they call as McFarland's test, where you look for any axis deviation. Important. While you're flexing the affected hip, whether it goes outward, that means if there is any axis deviation, it has a definite connotation, because any sectorial involvement where the head becomes spheroidal in shape will show you an axis deviation. So you all are aware that the expected range of motion in the hip joint, in flexion, abduction, adduction, medial rotation, lateral rotation, and extensions are very well defined in your normal patient. And then this is how you describe the range from 0 to such and such, or from fixed deformity to such and such degree. And Thomas test, as we all talked about, place your hand in the hollow of lumbar spine, flex the hip and knee of the affected side, and look to see if hip of the affected side lifts from the bed. So you must be able to flex the hip and knee of the unaffected side. And then you look to see if hip of the affected side lifts up from the bed or not, and then what angles it forms. The flexion of hip and knee of the affected side, and note the range of motion. Thomas test, that's how I think when there is a case-based discussion, this can be discussed. And then we go on to find out if what is abduction, how much is the abduction, and adduction, depending on where after you have squared the pelvis, and then whether there's a fixed deformity or not. So you got to stabilize the pelvis and hold the ankle with the other hand and then move it. So you have to be gentle while doing it, because this is all a matter of practice that you should have been doing it. But then the right method has to be used to assess these movements. Rotations. Both rotations have to be assessed, both in flexion and extension at the hip. Externally and internally. That means you flex the hip, in the extension of the hip, what you do is you hold the legs in extended position, both the legs, just above the medial malleolus, and then rotate your hips internally and externally, and note down what is the range of motion. While in flexion, you flex the hip to 90 degrees, or in a deformed hip, up to the level when the flexion is available to you in a fixed position, and then you rotate the hip in the medial and the lateral direction. So that will give you the understanding whether it is the same or different in different positions of the hip joint. And mind it, you got to also do that when the patient is in the prone position. And in a prone position, you do it in flexion of the knee joint. You flex the knee and then demonstrate your internal and external rotation. We'll come on to it when we describe the prone position. So this is how you test for rotations on either side. That means always a contralateral hip is available to you, which is normal. Mind it, we are discussing this from the point of understanding that only one hip is involved. And most of the time, we tend to give you one hip involvement, but of course, in practice, you might find both the hips may be involved, but then you have to note down the available arc of motion in both the hips whenever you are describing it. And that is how you do it. And of course, this is shown to you when the patient is in prone position, external rotation and internal rotation. So you can demonstrate at the same time. So examiner can ask you to demonstrate these rotations, which is a very favorite questions most of the time. And you should be able to clearly say that I'm doing it in extended position or a flex position, in a supine or in a prone position, and I'm comparing it with the contralateral side, and I can demonstrate at the same time on either side. You can also do that while sitting position. If examiners insist on you, can you do it in any position? Yes, sir, we can do it in sitting position, provided your patient is able to sit comfortably. There are certain tests that we have been, this femoroacetabular impingement has been one of the popular indictment in the hip pathologies. So flexion, adduction, and internal rotation test is the one which tells us if there is a pain produced at the terminal area or in the arc of the motion, then it gives you a suspicion that there is an anterior impingement. If there is a lateral or a posterior impingement, you do flexion, abduction, and external rotation test. And there are certain tests which you should be aware about, and that is what you call as an Allen's test, in which you can demonstrate which component of you can get a quick idea of which component of the limb is short, whether it is in the femoral component or the tibial component. And of course, you do know that for ascertaining the supratrochanteric shortening, you will have to resort to certain tests which you should be aware about. And then upper end length measurement, and that is you do upper end length measurement as the limbs are lying in the position, and then you do a true length measurement by squaring the pelvis and keeping the limb in identical position. So this is how you draw your Bryant's triangle. So you can be asked that how do you know that is it a supratrochanteric shortening? So you have to compare it from the normal side, from the contralateral side, and you draw your Bryant's triangle by palpating the most prominent part of the greater trochanter. At times there is a broadening or thickening and many a times you are not able to get a very good point of greater trochanter. What you can take is most of the time the highest level point that you can ascertain on the greater trochanter itself. Now, the other methods for measurements are that you should be aware about Shoemaker's line, the Nelaton's line, the Chinese parallelogram, and Kotari's angle if you want to have a quantitative assessment. While in lying down position, in a prone position, look at the gluteal wasting. If there is any abnormal bony mass which is palpable in the gluteal region, you got to distinguish it from the greater trochanter. The mass is whether it is globular in shape, whether it is abnormally palpable in the gluteal region and moves with the movement of the hip joint. Posterior superior iliac spine, ischial tuberosity, sacroiliac joint, are there any? You can palpate them very well, and also look for if there is any tenderness. Per rectal examination is most of the time not done, and you can straight away say that, sir, I have not done PR examination if the examiner asks you. Now, but it should remain in your mind that if the question is asked to you, you should be able to reply that, sir, I have not done it. It was possibly not required. So examiner may ask you, in which conditions would you like to do it? He said, sir, maybe if there's an old case of central fracture dislocation, or there is a pelvic mass, or there is a pelvic abscess. So you should be able to at least give these 3 points to your examiner. Now, the test for stability is very important, and that is what you say as a telescopy. So you ask your patient. Another test is whether he can actively raise the limb against gravity or not. That is straight leg raising. That is one. That gives you an idea whether there is a continuity of the stable arc. And the test of telescopy is that you should be able to bring the hip to the 90 degree. And what you do is push and pull. Push and pull. So now there is a kind of a controversy at times. Should you pull it first and push it then, or do you push it and then pull it? I think it can be done both ways, depending on how the patient is comfortable, and normally it is done in 90 degree of hip flexion and a slight adduction, say about 10 degree of adduction, to make it little facilitated while this test. And while doing this test, you should be able to hold the supracondylar area of the femur with your, if you are doing it on the left hip, you should be able to hold it with the left hand, grip it right from the popliteal fossa posteriorly onto the supracondylar region of the femur, and then pull it and push it. There are certain tests we should know which can be done for tightness of the muscle, that is iliotibial band contracture. Of course, it is mostly was in post-polio residual palsy, but also if you get a case of cerebral palsy, which is rarely given to you as a long case, is not given to you as a cerebral palsy. Alice test is should be done. You know that in a rectus femoris tightness, and it can be done while the patient is lying prone. And tripoid sign is for the hamstring tightness, and this can be done while the patient is lying straight, and then you make him sit, make your patient sit with the limbs absolutely straight, extended, and you find the patient falls back and holds his back onto the couch with the help of his both wrist, and not able to absolutely 90-degree to keep the leg straight. So Phelps test is basically for graciless tightness, and though it is mentioned here, sometimes it can also be done for sartorius tightness, but basically done for graciless tightness. So to complete the examination of hip joint, the spine and both knees must also be examined very carefully. And then you present your clinical findings and summarize them. Because it's important that you should be able to put them in order that this patient has, let's say the patient has got an antalgic gait with a fixed flexion deformity. How much is the fixed flexion? Fixed adduction deformity, if it is there, and telescopy is absent, is negative. Now, this is that is how you give your clinical findings, and then you state your diagnosis in order of priority of as per the pathology and differential etiology. That means you must be able to give your diagnosis, a pathological diagnosis, with as a differential diagnosis in order of priority. Say whether it is a tuberculosis of the hip joint, whether it is a sequelae of the septic arthritis of the hip joint, or whether it is a secondary osteoarthritis, maybe following avascular necrosis. So that should be in a order of priority, depending on your objective finding and the impression from the subjective data. With these words, I think I'll close it down, and then we can go on to maybe certain questions or maybe a case presentation that would possibly give us a more insight into the test that we have discussed. Thank you.
Thank you, sir, for this wonderful presentation. Very, very informative. Fantastic. So I think all of us have learned so much. I think I'm audible. Yeah. Dr. Sharma, sir, are you here? Yeah, I think I can see.
Yeah, I'm here, but I have a sore throat.
So for the case-based discussion, I think you can just run through the slides with minimal talking if it's not a problem with you.
As such, I
All
was
right.
just...
You can have a sip of water and go slow. Don't strain your larynx too much.
Yes, I was just wanting to add few points. Recently, I'd been a DNB examiner and an MS examiner both. So because of COVID situations, now they've stopped giving long cases of hip joint as a physical case, but as a virtual case. So a lot of things are asked in Wboa. So this lecture would be of great help, because if you have seen this and gone through this, lot of points are covered. Secondly, I think so if there is a case, I'll just have a look. Any questions in the meanwhile? I'll just
Any questions? The house is open to questions. Sir, I don't think there are any questions in the audio or the text format.
I suppose, do they use the chat box? No.
No, sir. I'm just going through the chat box, so there aren't many questions there. I'll just check YouTube as well.
Okay.
No, there aren't any questions, sir. Any of our regional faculty seniors, any questions, please?
Students know everything nowadays.
I don't think so. There are any questions.
I would suggest that the students should also use, I think West Bengal, Dr. Kaushik has written a very good book. If you can suggest your students to read his book. I think it's a very practical aspect and very beautifully written. I must appreciate that. And of course, S. Das remains along with S. Das, they should read Dr. Kaushik's book.
So we have a question from Karthik Nasipuri. So Allen's test and Ali's test, which is for LLD measurement, which is for the limb length discrepancy measurement?
Answer this question to him. It is the, you see, Allen's test is, Allen test, is a vascular side and that you do it in the wrist joint. And I think you should all know how to do this test. But Ali's test, as we discussed, ALLIS is the test which is done for limb length discrepancy. It is an outdoor quick test for you. When you are examining in the outdoor, you get an idea, well, this limb is short in femoral compartment or in the tibial compartment.
I think Karthik, you have your answer. Thank you, sir.
Yes, sir. I want to ask two questions because last PG course we faced that students has got some confusions that regarding the gate, whether gate should be described at the beginning of examination or at the end, because some examiners suggest that you say at the end, especially in those cases where there are a mixture or combination of type of gate.
I can understand that. This has always been different examiners doing a different kind of expectations. To my mind, I think a patient who has come walking to you, who's come walking to you, is very important that you can describe the gait right in the beginning. You say, there, sir, and because you won't like the patient to get up again and again. You see, the sequence that we have formed is that you make a patient comfortable. So he is most comfortable if you do the given test at the same time. You do the gait, you do the Trendelberg, you examine him while standing. Keep in your mind. Now, if the patient cannot stand, obviously you can say right in the beginning that, sir, the patient is unable to stand, so I have made him lie down. That's it. They're all, you see, obviously a fracture case will not be able to stand comfortably. And maybe if it is a very painful hip, he'll say, no, I don't want to stand. So you can say that. You can say that. But you go with the mood of the examiner. I think it's very important while doing your master's examination, the university-based examination would be different from a national board examination. You see, I understand that during the COVID, we have started doing a virtual presentation and we have made virtual cases. Now that has gone in a different direction. Now it's going to revert, because it's going to revert. That we'll have OSCEs, of course, but it's going to revert. In the university setup, we will always have assessment of the psychomotor skills of the student. So it is important that our students put their hands on the patient and they are able to describe things in a logical manner. So if, to my mind, I think a gait can be ascertained right in the beginning when your patient can walk, because you don't have to make him uncomfortable again and again.
Okay. And another thing, that in the presence of any fixed abduction or adduction deformity, whether the student should do the Trendelenburg test and then say that the interpretation may be wrong, or they should straight away should not do it. How should they approach?
You see, I suggest that a student should be able to do all these tests, and by the time he's finished the examination of his patient, he will know it, whether I should blurt it out or not. I can understand at present, at sometimes when it is a stiff hip as well as a short hip, so patient you can get confused. But then as he comes to know, when he examines his patient totally in a given mode, this is to develop a mode for the student, give him a objective assessment, so that what happens is, towards the end, when it's a stiff hip, his movements not available in this plane, so he need not to comment on the Trendelenburg test. But he should carry out this examination, but he should not give Trendelenburg test right in the beginning. No, not at all. I think only gait he should be able to explain, while Trendelenburg test he should keep in his pocket and bring it out at the appropriate time, or if the examiner asks for it. That's my suggestion, so that the student does not miss the flow of examination.
Right. Thank you. So another question in the chat box is that
we have a question.
Yeah, Soham, please go ahead.
Shagotam has asked, while examining the gait, how long or how much do we ask the patient to walk unaided?
Well, I think it's a very, very important question. I think which I missed to bring it out in my talk, because I've been traveling, so I just gathered my things on it. Didn't want to make it very elaborate. You see, you must at least let the patient walk at least 10 to 15 steps, and not once. He should walk. You should be able to watch the gait right from the front, from the side, and the back. These are the three important aspects when you are examining the gait. You should ask your patient to at least walk for 10 to 15 steps minimum. Some people say 20 steps, but I think 10 to 15 steps are good enough. 10 to 15 steps forward, and then you watch the patient from back when he's walking again. So from front, back, and from the side. These are the three aspects which you should be able to examine, because many a time you may miss the lurch. And another important point is that whenever you are doing, I think I missed one thing in Trendelenburg, I'll repeat. If there's a short limb, at times you may get confused. So you should be able to to equalize the limb, use the wooden board to equalize the limb, and then do your Trendelenburg test. So these are the points which must be remembered while doing these examinations.
Arnab, I wanted to add one point. Sorry, sir, I'm interrupting. I was an examiner with one of the examiners who was fond of asking Trendelenburg even with deformities of coronal plane. So in that, the answer that he was expecting is the patient should have free abduction. If he's having free abduction but no fixed adduction, you can comment on Trendelenburg test, but say it could be a false positive. That way. That was what his expectation was
Right.
when he was asking for Trendelenburg in a coronal plane deformity.
Hmm.
Kumar, sir, he was an examiner from Delhi itself.
I can understand that. You see, the very important thing for a student to understand is he should not get offended. Number one, he should be able to bring out that, sir, I have done this test, but this is now saying about false positive, false negative. Again, if you read the original text of Trendelenburg,
Yeah,
there's nothing like
there's
false
nothing like
positive or false. But we all have our own, impressions and connotations. So I think I don't think so. Examiner will give negative marks for all this. But you are absolutely right. You are absolutely right. These questions have been asked, and we have seen our co-examiners asking these questions, and they are baffling to the students. So my suggestion to the student is that you should examine your you should examine your patient in a sequential manner and only comment on these tests towards the end of your talk, not in the beginning. Don't say it in the beginning. And you are absolutely right that if there is if examiner is fond of it, well, sir, some amount of free abduction is available, so this could be a false impression that I have got. Absolutely right. Yeah.
One more question. Can gait be assessed on assisted walking? Like with the stick, or patient must be walked unassisted? So
No, you see, it is very important. When gait can only be can be assisted when he is having bipedal walking, and then you can qualify. You see, the whole point is how observant is the student. How observant is the student? The student, has he observed that does he walk with a stick? Does he walk with any assisted aid? So that is, if he is wearing a orthosis, naturally he'll say, I'll walk with the orthosis. He cannot walk without the orthosis. So this can be qualified, but actual gait can only be commented without any assistance. Absolutely right.
if the student is very thorough about crutch walking and cane walking,
Gee,
different types of cane and crutch walking, then only he should comment on assisted gait.
right.
If he
Right.
does not know what is 2-point gait, 3-point gait, swing through, swing two, he is landing in a soup. So if you're very thorough about your crutch gaits and different patterns of crutch gait, then only comment, or else say that the patient is not able to walk unassisted.
I think that is the safest mode for the student. Absolutely right.
Yeah, thank you, sir. I think there are no more questions. We can move forward. So,
I think Jayan sir voice is giving a little problem. So I said, can we do 1 or 2 case discussions? If
No, I don't have any
okay,
case
okay,
discussion.
okay. Then so we'll move on to the next session. I
No,
think
if you, I would say, do you have a case? We can just put one case. If you have a case, if it is available, then it's okay. Otherwise, we can go ahead.
I think, sir, we can go ahead with the short spine examination that you had
Okay,
said.
okay. Can I have I'll just have a sip of water. Eh?
Yeah, sure, sir. Sure, please.
Just I'll have a sip of water.
so in the meanwhile, if anybody having any question regarding the hip examination, because lot of confusions are there, and on the examination, because we have seen that expectation are different in different type of examination. So it's a great opportunity that you make it use of it and clear everything today.
Yeah, I think more PGTs should be joining. I'm hoping they will,
Yeah, a lot of people are saying in YouTube, but they are not putting their queries there. So
Yeah.
it's open now, no problem. We can take the questions from there. You can just
Yeah,
Good
even
evening.
my YouTube is open as well, so I'm just.
Good evening.
Yes, sir. Good evening, sir.
Good evening. Arnab, if you have time, then I can show you one hip test.
Yes, yes, sir.
Please,
That will
please,
be
sir,
great.
please
Please.
go ahead. Please go ahead. I think
Okay.
Professor Pal has very kindly wanted to show us a case. Sir, please.
Yes,
Very good evening, Dr. Paul.
good evening, sir. Good evening. Good evening, sir.
What a pleasure to hear your voice.
Thank you, sir. Thank you. Just I'm switch over to my computer. Just
Oh, please, yes.
2, 6, 4, 8, 4, 9, 0, 3, 7.
So in the meantime, we have one small question. What
Yes.
privacy should be taken during walking if in examination center not have enough private space for particular case? I'm not sure I got the question. Possibly it is. Pronovish, can you just unmute yourself and ask the question verbatim?
Sir, during the gate checking, the patient should be on underwear. But when I examine the gate, sir told that a minimum 10 to 15 steps should be walked. But
Okay, I got it. I got it. Thank you. Thank you. So basically, sir, what's the minimum amount of exposure required while examining gates? That is what he wants to ask.
All
If
right.
there is not a private space, maybe a lot of people are there, so that may be an issue.
You see, a gait cannot be assessed unless you see the patient walking. That is the most important thing. You see, why do we want to assess the gait? We want to assess the gait. What is his functional assessment? You got to know that the patient is having pain, whether the patient is lurching on the same side. So you need to have your observation on it for at least minimum of the steps. Just by 1 or 2 steps, he may drag himself. He may just drag himself, or he may put his muscles into spasm and hold it up and just drag. You see, you cannot assess it. So over a period of time, it has been calculated by observation that minimum that you should have is, even if you have a small space, 10 steps are minimum. But it is suggested that you do at least 15 steps. At least 15 steps.
Thank you, sir. I think Pal sir is ready with his hip case. Sir,
All
please.
right.
Pal sir, can you hear me? Pal sir, if you can unmute yourself.
Professor Pal, your voice is not there.
Okay. So is my slide is visible?
Yes,
Yeah.
sir, it is visible. It is
Okay.
visible. You are also audible now. Please, sir.
Okay,
Yeah.
So good evening, everybody. So this is a chief complaints of a 50 years old man who has a pain at right groin at the end of the day when he take rest since last 4 years. And the limping was complained of since last 1 year. I'm requesting Dr. Kumar, sir. So whenever you can stop and you can ask questions and you can comment by yourself. Okay, sir.
Okay, all right, yes.
Okay, so this is the chief complaints. So next one is the elaboration of the chief complaints. Actually, what I follow the history of present illness is consisting of 3 components. First one is the elaboration of the chief complaints. The next one is the important positive history in favor of my diagnosis, and important negative history to rule out the other possible diagnosis. And lastly, the cardinal symptoms like the appetite, loss of weight, bladder, bowel, and sleep, And these cardinal symptoms, whether they are affected or not, cardinal features, whether affected or not, because if they are affected, they indicate a sinister significance like the dissemination of infection or malignant disease or like that. So this is a part A of history of present illness, that is the elaboration of the CHIP complaints. So I have elaborated in this manner that my patient was apparently all right 4 years back. Patient had a significant trauma by falling from height and got pain at right groin and can't move the limb. Immediately, patient was admitted to the hospital and was operated with bed rest for 3 months, followed by walking with crutches. Now, 6 months after the operation, patient complained of full dilating pain at right groin area only after prolonged walking when he was taking rest, which is insidious is onset and progressive in nature. And for the last 1 year, he underwent another surgery, followed by limping and pain over his groin, which was aggravated by walking and relieved by taking rest without any diurnal variation. So that is basically, we are highlighting to show the rest pain from this elaboration of CHIP complaints. And this is the rest pain I've already showed, and this is the mechanical pain. For the last 1 year, is complaining of mechanical pain. So both the components of the pain is present in this case. Now the patient started limping. This is the elaboration of limping. That is, the patient started limping since last 1 year, which is initially painless but become painful after walking for some distance, and but relieved by taking rest and medication. Now walking distance gradually decrease, and activity of daily living of the patient gradually become restricted for last 1 year. Now, the initially patient can sit cross-legged and squat, but now the patient can sit cross-legged and squat with difficulty. So basically, this suggests there is a progressive symptoms or progressive disease. Lastly, the part important positive and important negative history. Important positive history in favor of my diagnosis, that is, there is no history of fever, evening rise of temperature, chronic cough, chest pain, reduced appetite, and weight loss, which ruled out the infective pathology. And there is no history of night cry. So they ruled out the chronic infective pathology, most probably the tuberculosis. And there is no history of morning stiffness and no history of pain in other joints and waxing and waning. That is how I ruled out the inflammatory disorder. Next is the cardinal symptoms. There is no history of loss of appetite, significant loss of body weight, bladder complaints, bowel complaints, and the sleep disturbance. So this is my ruled out the debilitating disease like chronic infection, TB, malignant neoplasia. So this is my CHIP complaints and plus present illness. Now past history, there is no significant history like significant trauma other than this episode 4 years back. There is no significant childhood problem like prolonged incapacitation or fever for 4 weeks. No history of surgical intervention after other this episode. That ruled out the refracture. They ruled out the surgical complications. They ruled out the childhood disease like developmental disease, Perthes disease, and the malunited fracture. And the personal history, that is, I followed this dictum, that is ABCDE. No history of allergy, alcoholism, addiction. No history of birth trauma, bleeding disorder. No history of contact with tuberculosis. No history of drug intake or addiction. An environment patient live in the Pakka house with annual income of 60,000. And there is no family history suggestive of familial disease, infection, and like tuberculosis. So this is the history, and how you analyze the history, that is the question. So there is a significant trauma, there is traumatic, so there is a traumatic disease, trauma around the groin operated. So that could be the trochanteric fracture, it may be intercapsular neck femur, that could be the acetabulum fracture, there may be fracture dislocations, and pain, initially the rest pain, later mechanical, and that is that may lead to malunion or articular deformation. And there is a progressive symptoms of disease which may suggest non-union with upward migration or the distal fragment, unreduced dislocation, or union in a good or malposition with complications like avascular necrosis. So I think that is how I analyze the history, because just at the end of the history, the most of the examiner may ask, what is your probable diagnosis and what are the other possible differential diagnoses? Isn't it, sir? So what is your comment?
Dr. Paul, I am actually impressed by the structured history that you have formed. And in fact, you have put them in the very right brackets. So you have also highlighted how to analyze in a very focused manner on the complaints of the patient. I think is very important. It's very important. And you have raised an excellent subjective data. This is what I call a subjective data, which is available to you by taking a very pertinent history, very intelligent history, so that you can now almost focus down. There are only 2 or 3 fractures that come to your mind by going into the detail and their complication. You see, this is what is the importance of taking history. Absolutely fine. I think the only thing that I would suggest that while having taken such an elaborate history, we should also be, very, very particular in our patients of the lower section of the society where we have a floor culture. The culture is floor culture. That means most of our patients perform their activities on the floor. So they at times are able, they say, okay, I'm able to squat. But squatting in which manner? Is it in the comfortable manner, which is absolutely flexed hip and flexed knee? Say they manage to squat by just putting their knee on the ground. And that is one point that can be elaborated. That's all. There's just a bit of a suggestion. Otherwise, it's an excellent history, very structured in a very sequential manner. I must congratulate you, Dr. Paul, for making this what you call PPT for educating the students.
Thank you, sir. So any other comments from other faculties, sir? Okay, so I'll proceed. So actually, I divide the any pen for the students, like any pen that can be mechanical, that may be inflammatory, or the infective neoplastic. It is basically it helps the student to categorize the disease. So because this is the same thing, that is at the end of the history, student may be asked, what is the probable diagnosis? So in that case, the broad category of the diagnosis can be sorted out. So that will help you. Just two questions: what is the aggravating factor and what is the relieving factor? So if the aggravating factor of pain is mechanical, that is activity, and the rest is the relieving factor of that pain, is the mechanical pain. It's just opposite. Rest is the aggravating factor and the activity is the relieving factor, is the inflammatory. But as the infective and neoplastic, as the pain is constantly present, so there will be always, there is activity is the aggravating factor, but there is no relieving factor unless it is taking some medicine or surgery, anything. So that is the way. Now the general survey of the same patients is a patient conscious, cooperative, build normal, asthenic build, nutrition is average, pallor is it is not present, cyanosis not present, icterus, clubbing, idiopathy is not present. Temperature is the patient is afebrile, neck veins are not engorged, neck glands are not palpable. Their vitals are like this, as I can mention here. So anything to be comment, sir, regarding the general survey?
No, I think absolutely fine. Yeah.
Okay.
Please go ahead.
Now so this is the gait of the patient. Is it visible, sir?
Oh yes, it is visible. Yeah.
Sir, is there a video?
Yes, it is a video.
No, video can't be seen, sir.
This can't be seen, na?
No, video can't be seen.
Okay. Oh, okay. So I think it's not seen. Okay. Still,
we can see the photographs. Yeah.
Okay. So the inspection from standing is the head central in position, right shoulder is same level, anterior thigh appears to be vested in comparison with the left. From the lateral side, there is no exaggeration of lumbar lordosis. There is surgical scar mark is present. It is 8 centimeter length, linear at the upper lateral aspect of the thigh. It is there, which healed by primary intention. So surgical scar, as Sari suggested, you have to understand. Now, standing from the back, there is a head central, right shoulder at the lower level, and scapula at the same level, but there is a scoliosis. How do you know the scoliosis? There is some, see, there is some trunk limb space is abnormal. Trunk limb space is asymmetrical. Trunk limb space suggests there is a possibility of this coronal plane deformity of the spine. And so this scoliosis immediately, if it is obliterated, once the patient is asked to lean forward. So that is basically, it's not a structural scoliosis, it is a compensatory scoliosis, most probably due to some hip pathology, and which should be confirmed by asking the patient to sit down and to see whether the scoliosis is completely corrected or not. When the patient stands, this right knee is flexed, that may suggest there is a possibility of limb length discrepancy, and also this wasting of the hamstring muscles, which is obvious on the back of right thigh. Now, inspection from supine position. See the ASIS. ASI is at the same level. Now there are some questions may be asked, how clinically or how to know whether it is the same level. So can anybody volunteer from the participant? How do you confirm that ASI is at the same level? There are several ways. That is, first of all, you have to examine it, and you have to see whether the line joining the both the ASIs remain at right angle to the umbilicus to the CPS. This is one. Second, if there is some doubt whether it is at a higher level or lower level, if it is at a higher level, then it may be due to adduction deformity, and then according to the theory, if there is abduction deformity abduction movement should not be there. So we have to check the abduction. So if the abduction is there, that indicates it is not a true adduction deformity. So in this way, this is a by this back calculation, we can easily understand whether it is truly at the same level or not. Next, the anterior thigh appears to be wasted in comparison. Anterior thigh is appeared to be wasted in comparison with the left side. Right lower limbs appears to be short in comparison to the left lower limb, as we can check the heel distance. It is a asymmetry of the level of the heel. Next is no exaggerated lumbar lordosis. We can, if you see from the side, and patella looks just away from the roof, as you can see here, but just from that may be some possibility of external rotation deformity. See, this is the same test as I'm doing. I'm showing that the ASI is doubtful. We have to do this, the angle on the both side. This should be the right angle. It is also the abduction adduction. Now, from inspection, sir, anything to be added?
No, I think absolutely you are going in an absolutely fine way, absolutely fine. Otherwise, I would say when you were examining the patient in standing, I would suggest that at that time, you should make the patient walk at least 10 to 15 steps, number one, so that you can find out the gait, because you don't have to you don't have to disturb the patient again and again, and also perform your Trendelenburg test and keep it in your mind, keep it with you performing the Trendelenburg test. This is what I suggest when you have made your patient stand.
Thank you, sir. Okay, now palpation, there is a local temperature is normal over the right scarpus triangle. Tenderness entry point is non-tender. Trochanteric tenderness is not there. Bitrochanteric compression test is also negative. Now, palpation of the confirmation of the bony points, ASI is at the same level, right trochanteric at the higher level than the left, which is not tender, not thickened, broadened, it's not irregular. A surgical scar mark of 8 centimeter at the upper lateral part of the aspect of the proximal thigh, which is non-tender, mobile, non-attached to the underlying structure, and healed by primary intention. There is a bilateral femoral pulse is palpable and good volume. inguinal lymph nodes are not significantly palpable. The movements, I follow this sort of chart. There's movements. The left side is the normal and right side is a disease. Flexion is left side as it is normal, so 120. It will be between 0 to 120. It should be ideally, as Sari suggested. This is not the right way. We have to write it down the range arc of motion. That is 0 to 120 is not. And similarly, on the right side, whether it is started with the 0 or not, and if it is a deformity, you can start with the 10-degree flexion deformity, or by 10 to 100 like that. And lastly, whether it is associated with pain or not. So internal rotation in flexion, internal rotation in extension, external rotation in flexion, external rotation in extension. As you can see here, the internal rotation in extension and the flexion is different in this case. Similarly, external rotation in flexion and extension, it is different. So there is some sectorial involvement of the femoral head, we can suggest. As you can, if you see the flexion, extension, abduction, adduction, of which the flexion is maximally preserved, whether the other movements, especially the abduction and the rotation, are maximally involved. So there is an asymmetrical involvement of the movements, which is suggests there is some mechanical defect of the femoral head. That is the basis of the sectorial involvement, which is clearly identified by this differential rotation. As you can see here, there is a flexion, as you can sectorial sign. I'm not going to detail, as Sari is elaborately discussed about that. External rotation, internal rotation, and the measurement. The measurement, so there is some apparent measurement followed by true measurement and of the gut measurement. So basically, there's a true shortening. Apparent true shortening is equal to apparent shortening, as there is no abduction or abduction deformity, and there is a 1 centimeter less gut on the right side. There is 2 centimeter supratrochanteric shortening that it is on the right side. And the special test I have done, that is a Tendelberg test positive. Telescopic test, it is a negative. An active SLR with or without resistance, that is a stent field test for the lateral tear. It is also it is negative. Other signs like other joints like the neurological, vascular, reticular endothelial system, they are also done, and there are no significant abnormalities detected. So Tendelberg test is an inspectopalpatory method. Patient must sit or stand from the back, as Jasar is nicely described. And there are some prerequisites. It is asked what are the prerequisites of the Tendelberg test, and what is the inference of the Tendelberg test, whether the Tendelberg test can be done in coronal plane deformity or not. If it is done, what should be the interpretation? So different types of questions may be asked in the examination. So summaries, this is extremely important. So this is my case. It's a 50 years old aged male patient. Is presented with significant trauma around groin, operated followed by dull-arcing pain in the right groin since last 4 years, which is incidence is onset, gradually progressive in nature. Then there is complaining of limping after walking or some distance, with pain aggravated by walking and relieved by the taking rest without any diurnal variation for last 1 year. There is no history of fever, evening rise of temperature, and no history of morning stiffness, pain in other joints. On examination, there is a short limb gait. On inspection, right quadriceps, right quadriceps and is wasted. Right limb appears shortened in comparison with the left side, with secondary scoliosis, which is compensatory to shortening of the right lower limb. Greater trochanter is at a higher level than the left, without any tenderness and the thickening. A linear surgical scar mark of 8 cm at the lateral side of the thigh, which healed by primary intention. On palpation, the anterior point is non-tender. There is restriction of the internal rotation and external rotation of the hip, which changed with hip flexion. There is sectoral sign positive, with asymmetrical restriction of the hip motions, of which maximally hip motion preserved is the flexion, maximum hip motion affected is the abduction and internal rotation. There is supratrochanteric shortening of 2 cm. And Tendelberg test is positive. So my diagnosis is a provisional diagnosis, a post-traumatic, post-operative Coxa Vara deformity without malunion of fractured neck of femur, with possible osteonecrosis of the right femoral head of 4 years duration in a 50 years old male laborer. So, sir, comment please.
I think is absolutely right, your provisional diagnosis. But how did you say Coxa Vera? Coxa Vera will be difficult for me.
Yeah, that may not be mentioned over here. It is a post-traumatic, my provisional diagnosis may be
Yeah.
stopped there, the post-traumatic, post-operative.
Yeah, with the possibility of a osteonecrosis. Yeah, because you have an axis deviation in your patient that is that has been elaborated already. Yeah, that's right. So I think Coxa Vera, because for Coxa Vera, yeah, you can say, because it becomes difficult to say Coxa Vera by just doing this examination, because otherwise what will happen, the examiner will suspect the student, oh, you seen the x-rays, my dear.
Yes.
So I think we need to be careful as a student, and postgraduate student should keep so many things in his pocket, so that he can, the examiner can ask later on why there is why you have a abduction range is restricted. Why do you think abduction range is restricted in this patient? So then you can thought process can come in.
Yes, that could be the diagnosis. Maybe the post-operative, post-traumatic, post-operative malunion of the proximal femur.
That's right. That's right.
Malunion to the proximal
Because
femur.
osteonecrosis will go more with the coxa valga. You see, wherever there is we say the supralateral aspect of the very well fixed hips in fracture neck of femur may lead to osteonecrosis of the supralateral aspect of the femoral head. So I think coxa vara should be kept in pocket.
Exactly.
Yeah.
And the differential diagnosis is the early degenerative arthritis following the post-traumatic, post-operative vascular necrosis, femoral head, secondary degenerative arthritis. So these are please go through please go through this differential diagnosis, whether that should be relevant or not, that it should be kept or anything to be added.
No, he can say in order of priority. In order of priority, I think if I was a student, I would have said in order of priority, I think it is possibly a malunited fracture neck of femur.
Exactly.
And now the patient has started painful activity. It's painful. So it must have undergone into secondary osteoarthrosis, because it's 4 years duration. So 4 years duration, though it is little early, but then they can go into, as the osteonecrosis takes place, then they go into degenerative change. So he can say that secondary osteoarthrosis, possibly because of osteonecrosis. I think is absolutely right. Can it be a central fracture dislocation? No, it cannot be a central fracture dislocation. But then he'll have to keep in mind that can it be a central fracture dislocation? No, because the rotations are not grossly restricted.
Exactly.
And you have a range of abduction and adduction available in this patient. So I think basotrochanteric fracture, yes. It can be a basotrochanteric fracture, malunited basotrochanteric fracture. And then it fits into a coxa vara. It goes into coxa vara. So fracture dislocation, very, very remote possibility of fracture dislocation, but it could have been a fracture dislocation to start with, which was reduced. How do I know that this hip was didn't have a fracture dislocation? I don't know. So it could have been a fracture dislocation of the right hip, which was a surgical fixation was done. Well, it is unlikely to be a infective arthritis. Very, very unlikely to be a infective arthritis. There is a positive history of trauma following with surgical intervention, following which he was much better. Then he started deteriorating. So I think it is a traumatic diagnosis. You are absolutely right. Except that I don't agree with the Coxa-Vara to be brought in right in the
Absolutely.
initial stage.
Absolutely. Absolutely.
Professor Pal.
Yes.
Professor,
Yes. Yes, please.
there is a question from the, I think one question is there, how to show or explain the axis deviation. Please explain that. There was a question.
Yes, sir has just described. So axis deviation, if you flex the knee, if you ask the patient to flex the knee, so what happens? It is normally what happens that there is a if you ask the patient normally, so normally the once in the journey to flex the hip, the knee will starts to go to the opposite shoulder. It is a normal side. But if instead of going to the opposite shoulder, if it goes towards the same shoulder or just away from the same shoulder, so if that is known as the axis deviation. So that is basically due to some the three-dimensional deformity of the proximal capital epiphysis. So just ask the patient to flex the thigh so that his thigh will come to touch the abdomen. So and see the journey, whether in this journey to flex the hip, whether the knee goes towards the opposite shoulder or not. This is the basically we have to check.
Absolutely right. I think, Dr. Paul, you have very well said that. At times, you may have to just give a little support onto the heel. Just hold the heel very gently of your patient and ask him to flex the hip to the maximum what he can. And you will see that instead of going in the same towards the same hip or towards the other side, it goes away from the midline. The hip goes away from the midline when you are flexing. Now that indicates that there is an axis deviation. There is an axis deviation. Absolutely. One can either do it actively also if the patient is pain-free or absolutely pain-free. You can do it absolutely pain-free, or you can hold the limb. That means the heel in the cup of your hand, and then ask the patient to flex it. No, absolutely right. You see, rotations also. This is demonstration of axis deviation. Yes. But then, if there is a differential rotations that are available to you in extension, and when you do flexion, asked to do rotations in flexion, there is a restriction of internal rotation, then you will find that there is a discrepancy in extension and flexion. This indicates that the patient has a sectorial sign is available to the patient. This means that the head of femoral head has either become spheroidal in shape. That this only indicates the spheroidal shape of the femoral head. You see, it's lost its globular shape. This is what it indicates. There is one more comment that I have while you are palpating for the lymph nodes. I would suggest that the iliac fossa must always be palpated for lymph nodes, that is external iliac group of lymph nodes, because they are very important sign for any infective pathology in the hip joint. This must be remembered by our postgraduate students while examining the hip for lymph nodes. And another point which has been very well emphasized is that no examination of the limbs can ever be complete without doing neurovascular examination. I think the case presented was very well elaborated and structured. Thank you, Dr. Pal.
Thank you, sir. Thank you, sir. So I'm stopping to swear. Okay, thank you, sir.
Pleasure, Paul, it has been excellent. I must say that. And I'm so pleased to see you.
Thank you, sir. Thank you, sir.
Okay.
Thank you, Dr. Pal. I would take this opportunity to welcome Dr. Swarnendu Samanta. Sir,
Yes,
welcome.
yes.
As
Thank
your
you.
session is the
Namaskar,
last
sir.
session.
Namaskar. I think namaskar to Jayan sir also. Jayan sir is also there. Yeah.
Yeah, I'm
Jan
here.
sir is there. He was there since the beginning, sir. Yeah.
Yeah, he
So
is there.
I think we can move on to the spine session, sir. After that, we'll go to Samanta sir for the knee session.
Okay. Okay. Yes, Dr. Samantha,
Sir,
my
namaskar.
best wishes and namaskaram. Namaskaram. And good to see you. Good to see you.
Good to see you.
I was not expecting that I'll see you so soon. But it's very nice. We just met a month back, is it?
Yeah.
Good.
Good, sir.
You see, they have asked me to talk about spine. Actually, I've been traveling. I've been away from home, so I don't carry those things with me. But then I'll note it down few points in my mind, and I'll just come out with it. You see, while examining the spine, you see, it is a very mathematical examination, and a student should be proud that he's got a spine case, because either you can score 100% or you can fall out. So both things can happen. So you need to have a very structured method of examination, and it is, I think, goes without saying that you need to have your neurology very well read. You must remember that there are 33 vertebrae in the human body, and there are about 31 pairs of nerve roots, and there are 23 discs, and you have a spinal cord which ends at L1 level, and then you have a conus medullaris, and then you also have a phylum terminate, and then you have your coracoid. So I think this is very simple, and one has to remember it very well. And another is another aspect is that spine is also affected in the similar manner as our appendicular system or any other part of the body is affected with. So it has congenital disorder, inflammatory disorder, degenerative disorders, infective disorders, and traumatic disorders. So most of the time that the cases that are given to the students are those of either infective, which is basically we have a endemic area that is tuberculosis of spine, or a trauma. Most of the time we look for tuberculosis of spine to be given to your patient, to our students. Also, another type of a case that is being given to you is a what we call as a prolapsed intervertebral disc. So it's important to know when you are taking history from your patient that I'll just summarize that age is very important, no doubt, because that gives you sorry, just a minute, I'll just take a glass of water. It's important to ascertain the age of your patient and the occupation, which remains a basic data raising. Then what has been the occupation of your patient, what is his age, and whether there is any history of trauma or not. Now, most of the time, the patient will come to you. If he comes walking to you, he can have three basic symptoms. Either the symptoms can be pertaining to axial symptoms, or patient may be having radicular symptoms, or patient may be having weakness, which we call as myelopathic symptoms, upper limb or lower limb. So if you remember that there are 3 basic symptoms that the patient can present to you with. And another important thing that he can have following all this is he can have pain. So all the parameters of pain must be assessed. He can have a deformity in the spine, right? Or he can have a weakness, a motor weakness or a sensory deficit. So, or he can have bladder and bowel involvement, or he can have, and another is that you should ask for constitutional symptoms. I think these are broader aspects that I think of when we are taking a history of a patient, and then you can elaborate each one of them accordingly. So in our day-to-day practice, if we can just remember that the patient comes to us with either axial symptoms, which are most of the time degenerative stuff, or he can come with the radicular symptoms, which may radicular symptoms are most of the time a disc problem, or most of the time a disc problem, or he can come with a myelopathic symptoms, that means weakness in the limbs, not able to walk, or not able to move his hand or fingers. So that is all a myelopathic symptoms. So with these broader history taking, I think we can proceed on to examination. So far as examination is concerned, again, if the patient comes to you walking, then it is a different thing that you have to examine the gait of your patient as he comes to you. And that means that whether the gait is spastic or not. I think that is the major thing that you look into, whether the gait is spastic or not. And whether levels of his shoulder, level of his head, is there any rotations like that you find in torticollis? And so you start right from top to bottom. And I think one of the pictures that Dr. Paul showed very well regarding scoliosis. So you have a scoliosis, which is which you can you can ascertain by the level of the shoulder, whether it is compensatory or whether it is structural. And you see, look at the limbs. There is a gap between the arm, between the trunk and the arm. So you see that whether there is a curvature to the right or curvature to the left. So you can examine that where the patient is standing, and then is there any swelling. Before that, you should be able to you should be able to see if there is a level of the shoulders and level of the scapula from behind when you are examining your patient, and any tilting of the head on left side or right side, any rotations, and if there is any bed sores, then that you see in the lying down position. Of course, those having bed sores, the patient won't be standing. And that is there any deformity? Yes. So you have seen whether there is where there is a curvature of the spine, or there is a bump in the spine, which we call as a gibbous or a kyphosis. And from the lateral profile, again, you see whether there is a whether there is any gibbous which is more prominent while you're seeing the patient from a lateral profile. You look for any sinuses, swelling, and puckering of the skin. And just like in spina bifida, you may just have a telltale story of a spina bifida. And there could be pigmentation, puckering, tuft of hairs. So all those points you must be able to note. Then you come on, after you have done this, then you can, at the same time, also, while the patient is standing, you can mark the spinous processes and also palpate the spinous processes. So while palpating, it is very important that you should mark your spinous processes from at least the most prominent part of the spinous process that you clinically are able to ascertain is in fact T1, because we say that C7 is the longest spinous process of all the cervical spine. But the one which you can clinically ascertain, which is most prominent, is T1. And then as a patient is standing, you can mark the level of the inferior angle of the scapula, the spine of the scapula, and down below, of course, on the highest point of the iliac crest, the line crossing there. And you also look for any dimple of Venus. And when you have marked all this, then you start palpating the spine, which is very important. And the palpation should be done by your middle finger. It is important that with the middle finger, you palpate the spinous processes from top to bottom. From top to bottom, you come down, and this gives you an excellent feeling onto the pulp of your middle finger, whether there is any prominence in the spinous processes. If there is an extra spinous process prominence, you must zero down that. Then you start examining whether it is tender or not. So the tenderness can be elicited. Of course, you can do that in the lying down position. We'll come down on it. But then you have, if the patient is walking and has come to you, then you'll have to do all these tests. And then you, in a walking patient, you do flexion, extension, rotations, and they are best demonstrated when the patient is sitting. At the same time, you should also be able to take the chest expansion of your patient. And the chest expansion can be done at mammary level, or it can be done at gyphoid sternum. Both of these is, in female it's difficult, but you can do that at gyphoid sternum. And note down what is the chest expansion like. And then you can do the movements of the spine. And cervical spine, the movements can be done. Flexion, extension, rotations, and little bending. And note down your ranges. And while sitting, you can do the best part of your lumbar spine movements. And then, of course, I think this would, and of course, I think the temperature and this, if you must be able to first, when you palpate, you must be able to also able to find out whether what the local temperature like, and any swelling, deformity we have already discussed. Now, depending on this, if your patient is a walking patient, then you can do a Schober's test by taking a tape, and you know that how much is the distance, right, 10 to 15 centimeters you take, and you take it from a fixed point, and then see while patient is flexing how much he opens up the spinous processes. That is important, and that gives you a lot of information. And so far as the mobility of the spine is concerned. Another is that while the patient is a walking patient that comes to you, then you do your special test, like you make the patient lie down, and you can do your what you call straight leg raising, passive SLR, and you lift the limb, asking your patient to absolutely leave the limb floppy and lift the limb up with holding the heel, and if the patient feels any radiating pain or not at certain level, which is most important, between 30 to 60 degree. Between, say, beyond 60 degree or some people say 70 degree, but I think 3 to 60 degree is the one, 30 to 60 degree is the one which is most important. And then you can add when he experiences the pain, radicular pain, it tells you that I'm getting a stretch pain. This is all a test for stretch pains. And you lower at the point of the stretch pain, you lower the limb, and again, what you call press on, do a dorsiflexion, and if it is positive, that is what we call as good Lassigre's test. So these tests can be performed, and there are many other tests which are available for cervical spine. I think I'm not going to go in detail of that. But let us do the examination of the patient while the patient is lying down. Now, all these things you can say that the patient is being examined in a lying down position. I have not been able to make the patient sit because the patient has got weakness in the lower limbs and he's unable to walk and stand. So you start doing then what you call as neurological examination, which we call as motor test. We do a motor and sensory examination of these patients. So the full neurological examination is a must. And before that, you should be able to higher mental functions, and cranial nerves must be known to all of our students. And as a matter of protocol, they should be able to say that cranial nerves are normal, because we don't give you any case with the cranial nerve injuries or cranial nerve affections, and power of stereokinesis and coordinated movements. And after that, you come on to the examination of the spine, in which you do examination of the spine most of the time in the lateral position, the most comfortable position. And then in that position, you will be unable to indicate the level of the shoulders, and shoulder level should not be commented upon. And what you do is you palpate the spinous processes, and wherever there is a prominence, you elicit the tenderness by giving a pressure onto the lateral aspect of the spinous process. And this is how you elicit tenderness onto the spine. And this is important because this, if you do that, you will be able to produce a rotational effect onto the vertebrae, and that will give tenderness onto the anterior part of the vertebral column. With this, the muscles, paraspinal muscles may stand out, and there has been a confusion at times. Some people have been talking about tapping the muscles to get the spasm. No, tapping a muscle will give you that's not the way to demonstrate tenderness onto the spine. That is what do you call a neurological spasm, that you are irritating the muscle by just tapping it. That is not the one which is being irritated by the underlying joint. So one must distinguish between it, and should take away the confusion on this. So another important part is while examining your spine is that if there is a involvement of 2 vertebrae or 3 vertebrae, you can distinguish by counting the vertebrae, the spinous process from top to bottom. Then you come on to your neurological examination, of course. And what I suggest is that neurological examination in any given case of paraplegia should be done right from top to bottom. That means upper limbs, you should be able to say the upper limbs are normal if it is a paraplegic patient. And then you come on to the examination right onto the intercostal muscles, whether the patient is breathing normally or there is a paradoxical breathing, and and you try to pick up one muscle for one root value, and that is I say that in upper limbs you take abduction, that means deltoid for C5, and you take your flexion of the elbow of C6, and C7 your what you call as triceps, and C8 as your flexor, the what you call the deep flexors of your digitorum for the of the middle finger, and T1 you take abduction of the little finger. Similarly, in your chest, you are examining right onto your intercostal muscles, whether they are opening up or not, or there is a paradoxical breathing. When you come down onto the abdomen, you must do a Beaver's test. You must do a Beaver's test, and you will know whether the lesion is affecting the D10 level or below it or above it. And then come down onto your lower limbs, L1, you see the hip flexor, the iliopsoas, and sorry, L3, and your iliopsoas, sorry, L2, I'm sorry, L2 level, it will give you L2 level basically. And when you come on to the quadriceps, it will give you L3 level. You come onto the ankle, it will give you about L4 level. So you picked up one dorsiflexion, quick examination, and then you come on to your great toe, and that will give you L5 level, and flexing of the extension of the great toe will give you L5 level, and flexure will give you S1 level. So this quick examination of your muscle power can be done while a patient is lying down. Similarly, your sensory deficit should be very well done by knowing your dermatome in the upper limbs, as well as in the chest, as well as in the lower limb. And then you come on to your, basically onto your, let's say, you come on to your reflexes. So superficial reflex and deep reflex. So superficial reflexes, you do abdominal reflexes, and abdominal reflexes in the upper quadrant and the lower quadrant, right and left, should be done. And then you should do your Babinski test, and after that you can do, of course, in males you do a what you call as males you do I think bulbocavernous reflex can be done, and you can do that. Bulbocavernous reflex. Patients, those who are on the catheter, you can give a small tag in the catheter and look at the anus. And another test that you can do is Babinski, of course, and then you come on to any clonus, whether the clonus is there in the ankle clonus, whether it is, I think one should be able to say about sustained, ill-sustained, well-sustained, or ill-sustained. I think these two don't go into the details of degree of clonus, but whether it is ill-sustained or well-sustained. I think that will suffice. And at the same time, you can also elicit spasticity, and that is what we call as cleft knife type of spasticity, which is most important. And after that, you, of course, dermatomes, your dermatome involvement, we have already discussed. And then deep reflexes, and for the upper limbs and lower limbs. And their root values should be well, the root values should be very well remembered. And then another thing that now you have almost got your data with you, almost got your data. You've got a full, what you call, objective data available to you. And then you can start analyzing whether it is upper motor neuron or a lower motor neuron. If it is, and then upper motor neuron and lower motor neuron, and you should know the difference between the two. And then you start finding out where is the sensory loss. And when you sensory loss, let's say at T10, now if you find that sensory loss is as T10, and you know that then you have to understand the levels of the cord. How do we add up onto the levels of the cord with the vertebrae? So you start right from, let's say, in cervical spine, at C7, you add 1. In the cervical spine, you add 1. And while in thoracic spine, you from 1 to 6, you must remember you add 2. And from 7 to 9, you add 3 segments. And at T10 is represented, thoracic 10 is represented, representing the L1 and L2 segment. While T11 will represent L3 and L4 segments, and T12 will represent L5 segment. So, and the cord will end at L1 level. Then the L1 level, you have a sacral segment, and then you have, of course, your conus medullaris and phylum terminal and your chora equina. So now you will know that what in a sensory loss. You say, let's say sensory loss at somewhere around L1 level, or so you know that if it is L1 level, that means somewhere it should be thoracic 10. Now say thoracic 10 level, so thoracic 10 vertebrae. So that's how you start correlating. So that means you must marry your findings with the clinical observation, and an upper motor neuron or a lower motor neuron. So you will be able to now come on to a diagnosis. If it is in the upper motor neuron, that means the patient will have some kind of a compressive myelopathy. And if it is a lower motor neuron, then it may be either radicular symptoms or chora equina syndrome. So then you start analyzing that whether it is extradural. That means extradural either in the bony or in the soft tissue or in the extradural region, and whether it is intradural, extramedullary, or it is intradural, intramedullary. So these are the classification that you should keep in mind while you have. While you're analyzing your observations clinically that you have made. While in trauma case, of course, you will have to remember in the trauma cases again the same thing, but you will have to analyze the muscles individually, muscle groups, and rather than picking up one muscle at a time. I think. Almost I have given you a very broad outline of a spine examination. Thank you.
Thank you, sir.
Yeah.
I think this was really elaborate one, and I think most of the things, I think if they have been listening carefully to you, they have understood.
Absolutely, sir. It was a wonderful, talk. Very, very elaborate and detailed about the entire, spinal examination and everything. I think we have a small question. Is it necessary to mark each spinous process, and what points to mark on a spine case?
You see, I think you need not to mark each and every spinous process, but for counting, at least you should be able to mark in a paraplegic patient at least 2 places, at least one thoracic 1, which is the most prominent clinically, and the highest point of the iliac crest, because rest of the points that you have in a paraplegic patients are not exact. You see, so these 2 points are very important, and they're good enough to count your vertebrae. And another thing is that if you have a prominence of the vertebrae, that vertebrae must be, that spinous process must be highlighted. So you can count the vertebrae. It is not necessary to mark each and every one, but it's good to mark, because in a lying down position, but then you see the positions can change. You must be able to say that I have done it in a prone position or I have done it in a lateral position. You know, many a times what happens, we have observed during these examinations, the student can get worked up, whether he should, when he's changing the positions, when he's showing you in the lateral position and then making him supine, these marks change, because this will depend on the positions. So you should be able to mark, at least to my mind, these 3 marks, and so that you can demonstrate to your examiner. And there can be small changes, but it is all acceptable, because nobody can be absolutely exact. So at least you have tried, you have shown to your examiner that, sir, I have marked these spinous processes to count the vertebrae, because this is how I count it. I did not mark at the spine of the scapula or the inferior angle of the scapula, because they are mobile structures. They are mobile, so they will not give me any indication.
Right.
So this is what I would suggest.
Right. Thank you. I think we would move on to the last session for the day, the knee examination by Shamanta sir. Sir, please.
Thank you, Kumar sir, for your nice explanation on the hip and the spine. Now we'll be just having an overview of the knee examination. Okay, Soham?
Yes, sir. They're all ready.
Good.
Just if there is any question, you take some time, because I have to just 1 minute. I have to just locate. Okay.
I know that this spine examination, possibly because I didn't have the slides along with me, so I could not tap all these. So I thought I will just talk about it, and if I know that there will be a lot of questions, and I would welcome them, and so that we can clarify certain things. But my suggestion is that whenever you're doing a neurological examination, especially, you should do from top to bottom, so that you do not miss. Many times, what you have is upper limb involvement as well. So you should do right from top to bottom, and you should be able to also do a Beaver's test, because many a times the expansion of the chest and the Beaver's test are missed by the students, and they give you a lot of information, and also give you additional points when you are presenting your case. Of course, the vascular examination should also be done. That means you must palpate all the vessels. You must palpate, and especially the abdominal aorta as well, because many times, I know though it is rare, but then abdominal aorta must be palpated in all spine cases.
Absolutely, sir.
So you can run from your side. Otherwise, there is some delay from my side. If you can give me 30 seconds, I will be joining. Okay. Just 1 second. I have just looked at.
Sir, please take your time, sir. Yeah.
Uh, could I be
Thank you, Kumar sir.
could I be excused? You know, I have to just rush
Yes,
for.
sir. Yes, sir. Thank you so much, sir. Thank you. Thank you very much for your time and valuable opinion and valuable presentation. Thank you. We are very much obliged, sir.
Oh,
Thank
my
you.
pleasure. My pleasure, Somyo. And thanks to the
Thank you,
faculty.
Okay, sir. Hope we will
Thank-
meet in Kolkata soon. Okay,
Thank you,
sir.
sir. Thank you,
Okay.
sir.
Okay,
Thank you, sir.
okay, Paul. It's been a real pleasure, and thank you, Samantha, and my young man. Thank you, dear. Thank you so much. Thank you.
Thank you, sir. Okay.
Thank you, dear. Okay, bye-bye.
Bye bye, sir.
Bye.
কতদিন হয়ে গেল তুমি বলো এগুলো বাজে না বলো তো অরিজিনাল দড়ি অরিজিনাল
বাবা। সোহম, আমার মনে হয় এবার আসবে, জাস্ট 1 মিনিট।
ঠিক আছে, নো প্রবলেম, নো।
দেখ তো আসছে কিনা।
এসে গেছে স্যার, স্ক্রিন শেয়ারিং দেখছি, মানে প্রেজেন্টেশনটা ইটস ইয়েট টু স্টার্ট, বাট আই ক্যান সি ইউ হ্যাভ স্টার্টেড স্ক্রিন শেয়ারিং।
Okay, I think এটা I think now it is there on the screen.
এখনো স্যার স্ক্রিনে আসেনি ওটা।
It is,
না, নট ইয়েট, নট
I
ইয়েট।
think it will take some time
আরেকবার
because
অফ করে অন করুন। স্যার বলুন। Dr. Ashok Sham sir, yes, audio is there. Actually, we are just waiting for Dr. Shamanta to get on with the presentation. There seems to be some technical problem. He's not able to do his screen sharing. We are trying to get the presentation started in some other way. Okay, sure.
Hello, Arnav. Hello. Hello.
স্যার বলুন, আছি, tell me.
ওখান থেকে চালা, এখান থেকে করা যাচ্ছে না, নেটের প্রবলেম আছে এখান থেকে।
I am just trying to download it. Abhishek is trying. I am also trying to download and screen share from my own screen. Just give me 2 moments, because অর্ণবদাকে ফোনে আমি পেলাম না। I was না আমি
নো
লগ
প্রবলেম।
1 সেকেন্ড জাস্ট।
আমার নেট
Good evening, sir. Good evening, sir.
Good
Sir, I'm also trying to open the document here. I'll just
Okay.
update you. Abhishek.
Somehow the net connection went off. Now I am joining from the mobile. I think you just run over there, then I can do my job.
Yeah. Sure, sir. Sure.
ওটা হয়ে গেছে, মোস্টলি will be on.
হচ্ছে না, নেটটা আটকে গেছে তো, স্ক্রিনটা আটকে।
Can you see, sir? Is it visible?
Now it is visible. Now it is visible. Okay. Hello. Soham,
Yes,
it is visible now.
It is being shared, no?
Yes. Yeah. Yes, sir. Yes, sir. Kindly start, sir. Kindly start.
I think during the last PG course we have already discussed about this part of the knee examination, but I will just run through and whatever, because knee case will definitely come as a short case, not as a long case. But you have to be very particular about your some clinical tests. Otherwise, it is very difficult to impress the examiners. So when you take the history for your knee case, it can be either non-traumatic or traumatic one. Mostly for your non-traumatic, you can get some sort of infective etiology or else some tumorous condition, some exostosis, your patellar subluxation, the habitual dislocation, all these cases you might be getting. And some cases you will be getting for the trauma, you might be getting some meniscal injuries, because meniscal injuries are sometimes painful, so you don't get those in the exam. But you might get your ACL injury or a PCL injury. Okay. So traumatic history is very, very important, whether there is a trauma and whether what is the nature of violence, then what is the position of the knee, direction of the violence, and whether there was any giving way or locking symptom. Next one. So like your all orthopedic examination, you have to go with the look, feel, move, and special test. Similarly, it is very true for your knee also. You look from your front, from your side, from your back, so you can appreciate. So I will categorically go one by one quickly. Next one. Also, this is very important as you examine your spine and knee. Your gait is also very important, because you have to whether the patient is able to walk or not. Walking is possible. If there is a stiff knee, there will be leg swing, or other sometimes you might be finding some painful gait or lurching gait to the normal side. Next one. And also you see the alignment from the front and also from the back. Also you examine the knee, whether there is any gross deformity, like whether it is normally aligned or there is a varus or valgus deformity. And whenever you are examining your knee, also you see the thigh, also you see the leg, and also you examine from the back side also to see and examine from the front your foot and the heel. Next. So if there is any effusion also, you have to see carefully that sometimes there might be gross effusion, gross swelling. When there will be finding the horseshoe shaped swelling is like your effusion. Then sometimes if there is acute, probably you don't get these acute cases, or the pyarthrosis you don't get in your exam. But if there is any effusion, you please do mention. And sometimes you might find some sort of fullness around the parapatellar region if there is ligament, the patellar tendon, because there is minimal bending. There will be some fullness around or just beside your patellar tendon. Next. Then you have to feel. Also, you have to look for the wasting, and when you see the wasting, sometimes this is asked in your exam, where to measure and what to see your wasting. Always remember, it is not any fixed point from the patella where you find clinically or by your look where is the maximum wasting or where there is a maximum girth is there on the normal side. There you take the measurement. It's not like 7 to 10 centimeter from the top of the patella every time. Next one. So movement, as you measure like your hip, you have to mention like your active and the passive range, and also you have to mention the limitation, the crepitation, and the pop-up sign, or the how the patella is going and the whether it is painful, yes or no. Next. Then if there is a palpable click, you have to understand whether this is because of the osteoarthritis like your crepitus or a slipping tendon. Sometimes there might be slipping tendon, the IT band might be slipping, or the semitendinosus or the biceps. And loose body, sometimes the patient can experience, he will be even from the history, you can know that there is, if there is occasional locking or the painful locking is there in the middle-aged people, then you might know that there is a loose body. Next one. So movement, as I think you have to know the normal range, and also the flexion. The normal flexion is the cup touching the thigh. Extension is sometimes you have to see some 0° whether it is coming yes or no. Some people, they are ligamentous laxity, they are going into hyperextension. Always see the elbow, the finger, and so that you can have the Python score. Never forget that if the knee is going into hyperextension, don't forget to check for the generalized ligamentous laxity. Okay, if there is some also you have to take the range, always mention, because if there is any locking or any sort of synovitis or any crepitus, you also mention, you can feel during the movement. Next one. So anterior knee examination, you have to see the patellar grind test. Remember, this is a very important one because knee is flexed to 10°, glide the patella distally and firmly compress the patella against the trochlear groove. Then only you can understand, because if there is a young or adolescent guy, sometimes you, because of the OCD, osteochondral defect, you might find that the patellar grind test is positive. Next one. So patellofemoral joint also, you have to see whether you can evert the patella, because sometimes if there is, you can evert because the patellar laxity or the habitual dislocation or the recurrent dislocation, that you can understand from the history. So you have to see and evert how much the patella can be everted and how much is patella is going medially and laterally. Sometimes you have to check for the apprehension test, because if the guy is having habitual or the recurrent dislocation, then there will be apprehension when you try to push the patella to the lateral side. Next one. And also during the movement, suppose you just hang the ask the patient to hang the limb from the side of your couch and see the patellar movement. Now this is the J sign. I will request you read it, because you can get the recurrent dislocation or the habitual dislocation. You will find the patella goes in a manner from extension to flexion. It will not go in a straight line. It will go from a straight line, then you go to the lateral side. So this is the classic J sign for the patella. That you have to read, and you might get this case because these are not very painful knees, and if the case is there, you'll be definitely get it. Next one. So measurement also I am not going to detail, because this you can read from your theory books. And always remember how to measure the Q angle. Q angle is not a radiological angle. It is always a clinical angle. Remember, this is always a clinical angle. Next. So Q angle, you have to see the patient standing, and you have to see from the anterior iliac spine to the middle of the patella, then to the middle of your ankle, and then for the male it is 10, for the woman it is 50. Remember this degrees for your, because you might be asked for. Next one. And also measure the if there is gross deformity, varus or valgus. I think you all know how to measure the intermalleolar distance or the intercondylar distance in the knee. If there is a varus deformity, if you get that, please do measure, because if you don't mention them, then it is a gross mistake. Next one. Now come to the special test. I think this is the most important part that we have to understand. Okay, so if there, you always remember this side very carefully. Whenever there is a collateral ligament injury, there is a varus or valgus stress test, and the AP laxity is for the cruciates. So IDK, that means your the internal derangement of the knee because of the meniscus, or for the loose body it might be. Next one. So meniscal examination, always remember, if the examiner will ask you which is the most sensitive test, always remember that last time also I stressed it, that joint line tenderness is the most sensitive test for your meniscal injury, not your McMurray or the Apley grind test. Next one. So stability, you have to check for the collaterals like the MCL and LCL, then the ACL and PCL. Always remember that when you check the varus or valgus test, you have to check in 0 and 30 degree. Why? In 0 degree, suppose you take your valgus test and 0 for the MCL. When you test at 0, basically you check the your posterior structures, POL you check. But if you flex this to 30 degree, then you check the MCL. The examiner will classically ask you whether to check the MCL in 0 and 30. Always remember, MCL is checked at 30 degree or 15 degree flexion, not at 0. And you once you test the valgus at 0 degree, usually you check the posterior oblique ligament. Your posterior structures are checked. Same is true for you when you check for your varus test for your LCL. LCL is checked in 15 to 30 degree of flexion. When you extend at 0, then you check your posterolateral corners. Next. And also this is the classic varus or valgus test at 0 and 30 degrees. So this is the way you check both the posteromedial structures, posterolateral structure. Always remember, the posteromedial and posterolateral structure are checked at 0, and the MCL and LCL is checked at 30 degree of flexion. Remember this one. Next. Next. So also, I will tell you that you read how to check the McMurray's, because unless we are demonstrating this clinically, it is very difficult to explain. But remember, for the medial meniscus, you have to externally rotate, and for the lateral meniscus, you have to internally rotate. And from the flexion, you gradually come to extension. And at which point the patient asks for the pain or there is a click, then you know that there is a meniscal injury. So for medial meniscus, you have to externally rotate the foot. For a lateral meniscus, you have to internally rotate the foot. And this is the classic test, because I think you will be definitely, if you get a knee case, you will be most of the time you will get a ACL. They will ask for the 4 prerequisites for the ACL, the anterior Doyer test. Okay. Remember one by one. One is the 45 degree flexion of the knee, then 90 degree flexion of the 45 degree flexion of the hip, 90 degree flexion of the knee. Then the foot has to be fixed. You see that the examiner is sitting on the foot. It should be planted on the couch, and you have to see the hamstring is relaxed. So these 4 points you have to remember for your. This is the prerequisite for the anterior Doyer test. Okay. Then you check like this way. I think the last PG class also we have explained all the clinical tests with the volunteers over there. So remember that these 4 prerequisites for your ACL. Next one. And also you have to understand what is a Lachman test, because Lachman is done for the acute knee. For the chronic knee, you do either the pivot shift or your anterior Doyer. Okay, Lachman, why you do? Because sometimes you cannot flex the knee to 90 degree on acute knees. That's why you do the Lachman. Also, why you flex then the examiner will ask you why you flex to 15 to 30 degree. This is because of the door-stopper effect of the meniscus. Because if you don't flex to 15 to 30 degree, the meniscus will prevent the anterior shift of the tibia. That's why we have to flex the knee to 15 to 30 degree of flexion. Then remember that you have to keep your left hand on the top of the patella, and the other thumb will feel the anterior glide of the tibia, so that you can appreciate how much tibia is coming in front. If it is coming more than 5 millimeter, 6 millimeter, then is a positive test both for the anterior Doyer or the Lachman. Next one. Then you have to understand how the pivot shift is done, because this is the classic test. They will ask you to show. Sometimes this is painful, so you don't test many a times. You just ask the patient, always explain what test you are going to do, because the examiner will see how you are doing. It is not the actual test. Always remember, in orthopedics, whatever test you are doing, you first explain to the patient, then they ask the examiner that I will, sir, do it on the normal side, then come to the abnormal side. Don't jump. Just if they ask you, show the pivot shift, don't jump and do it. Always follow the protocol, explain the test, then do on the normal side, uh, show the patient, gain the confidence, then you come to the abnormal side. Probably the examiner will not tell you, okay. If you tell this to the examiner, they will, okay, no, now you explain. But if you don't tell, they will catch you. Next one. So pivot shift, remember that there are three components. Why it is known as pivot shift, I told you. Just go back to the yes. The pivot is the MCL. So if the MCL is torn, you cannot do the pivot shift, because from the midpoint, it has shifted to the MCL, medial side. That's why if the ACL is gone, now the pivot is shifted to the MCL. So there are few things that you have to remember. One is the valgus to the knee, internal rotation of the leg. Then you, from the flexion, you go to extension. Because why you do this? Because in 30 degree of flexion, the IT band becomes the extensor. So once you give the valgus force internal rotation, now the tibia is subluxated. Now once you go to the extension, the IT band will relocate the tibia to the normal position. So you will feel the third, you will feel the click, and also the patient will feel that the now is relocated. Now the patient will also feel it. Next one. PCL also you have to see clinically, that's sac sign, classic sac sign. You have to see whenever you have to see from the side. So you have to go to the side of the patient, then you see whether the tibia is gone back. Next one. So this is the classic sac sign. Can you see that the tibia, if you compare, then always remember that you have to see from the side, not from the top, because once you go to the side, then only you see that, compared from the normal side, that this tibia has gone back if in comparison to the other side. This is the classic sac sign. Next one. Now this is known as the Godfrey test. It's the same side, same thing, only because if you flex the hip to 90 degree, knee to the 90 degree, and then you just hold the heels, and if you see from the side, because of the gravity, the tibia will go back. So this is also a sac sign, and this is known as the Godfrey test. Next one. So now you see the same thing. This was same thing. You can see the tibia is gone back. This is the classic signal, the sac sign for the PCL. Next one. And all this is very important. Please listen to carefully. This is the dial test. Dial test is done for the PCL and the PLC. Always remember that this can be done in both supine and prone. But usually, if you are asked to do it, tell the examiner that this can be done in both in supine and prone. But most of the examiner, they will love to see in prone position. So what you do in this dial test, you just flex the knee gradually to 30 degree, then you externally rotate the foot and see the position of the foot. Now suppose this is done in supine. If you see the right side, it is more externally rotated if you than the left side. So in 30 degree, if there is more external rotation, that means 15 degree more external rotation in comparison to the normal side, then you know that this is a PLC injury. So in 30 degree flexion, if there is external rotation more than 15 degree, this is PLC injury. And in 90 degree, if the external rotation is more, then it is a PCL injury. But if from 30 degree to 90 degree, it becomes more, then this is a combination of PLC and PCL injury. So remember, in 30 degree, if the external rotation is more and it is not increasing in 90, then it is a PLC. If there is no external rotation in 30 degree, but there is external rotation 90, then there is a PCL injury. If there is more external rotation at 30 at which increases at 90, then it is a combination of PLC and PCL injury. Okay, next one. So so if there is a difference of 30 degree, as I told you, remember in 30 degree it is PLC, 90 degree it is PCL, and if it is increased in both, then it is PCL and PLC. Next one. External rotation recalibration test also sometimes you have to do. It just read from the Campbell. It is beautifully written over there. Just you have to hold the great toe and see that the tibia goes into hyperextension and external rotation. This is the classic signal or the sign or test for your PLC injury. Next one. And also the reverse pivot shift, I will tell you, this is not been asked in the examination, but if you read it properly for the reverse pivot shift, I think next time whenever we get scope to show you clinically, because it is hard to explain, but dynamically assess for the post. This is for the posterior lateral knee rotational injury. Next one.
Yeah, finished, sir.
I think the most important part that you remember for your clinical test, that you don't forget that the Q angle is a clinical angle. This is not the radiological angle. The joint line tenderness is the most sensitive for your meniscal injury. The your varus and valgus both you have to test in 0 and 30 degree. So that in 0 you will be testing the posteromedial or posterolateral structure. When you flex to 30 degree, then you test the classically the LCL and MCL. Then anterior there, I told you the 4 prerequisites. In Lachman, why you flex to 15 degree? To avoid the doorstop or effect of the meniscus. For the PCL, you remember the Sack sign, Godfrey sign, and also the posterior Droit test. Okay. And for the dial test, I have told you in 30 degree for PLC, 90 degree for the PCL. If the both are increased in 30 and 90, this is a combination of PLC and PCL. And for patella, you remember, you see how the patella is tracking, and the J sign you test, and the apprehension test. You don't forget. Always remember to test the patella grind test, because if the adolescent guy is there, then you might miss the osteochondral defect, OCD or the osteochondral defect. So I think this is because knee you will be definitely getting for the only short case. So if you are through with this test only, I think it is more than enough. If anything is to be added, I think Abhishek is there, Soham is there. If anything is added, you can just remind me. Thank you very much for your kind and patient hearing.
Thank you, sir. Thank you, sir. It was a pretty elaborate explanation and pretty excellent presentation on the knee. So actually, the thing is that as knee is mostly a short case, which we get in the DNB and the MS exams, sir, I have
yes,
taken the opportunity to make a list of some of the common cases which we were taught in our postgraduate days, and that. So if you can just mention 1 or 2 points in brief, because you have explained most of the things in detail in your lecture. Sir, first one is when we get a genu valgum or barum case. So, sir, in that case, something which you would like to add, which the students make a common mistake when you have examined
yes, I think I have also during the lecture I have told you how to see the genu varus and valgum, because you have to check from the front and back, and also you have to see the foot, because in genu valgum you might miss the flat foot, and also sometimes you might miss the heel valgus. So examiner will catch you whether you have examined the foot or whether you have seen the arch of the foot. And also whenever you see your genu valgus, always tell them that whether there is any you have examined the hip, yes or no. And also whenever you measure this, the intermalleolar distance or the intercondylar distance, you mark the malleoli, you mark the medial side of the knee, so that your marks would be there on the patient, so that you remember that the examiner will ask you about these distances.
Right, sir. And so the So the next case which I would like to mention is so quadriceps contracture. What to see in the knee, or what the like rather what is the common mistakes which you have seen in your long illustrious career as an
Yes,
examiner, sir?
because from the history also you can see the whether there is a quadriceps, because nowadays it is not that common, because in our time there was injection in the thigh, so that's why sometimes the quadriceps contraction is there. Classically you are not getting the quadriceps contracture because of the injection, but because of the post-traumatic nowadays we are, or the post-op cases, you can find the extension mechanism contracture. Okay, so remember that you have to take the history properly, see for the scar, and now if there is a quadriceps contracture, always see there are two components. One is the intra-articular component, another was the extra-articular component. So remember that you have to check the mobility of the patella whenever you see this sort of contracture in the extensor mechanism. See how much is the mobility. If the mobility of the patella is not there, you certainly know that you have to tell the examiner that this is the intra-articular component is there. Then you have to check in the prone position also how much because you have to check for the rectus. You know the over test and all these tests you have to, for the rectus also you have to check the whether in the prone position you can check the rectus is tight, or also your lateral the IT band is tight. That all your test has to be done for the quadriceps. But don't forget to check the history of the trauma, any scar on the backside which might be hidden in the garments, that you have to check in the upside. And also check for the, remember that the knee stiffness is always of two components, one the extra-articular and the intra-articular. Check the mobility of the patella. Always examine whether there is any rectus component is there, and also on the other side your IT band contracture is there. Okay.
Nice, sir. And so one more, I suppose a very common short case with students encounter, sir, the TB knee, like the triple deformity. Sir, any specific points, or rather any common mistakes which the students make while presenting a case of TB knee?
TB knee, in our time it was there very common, but nowadays we are rarely finding.
It's not very common. It's not
it is
very
not very. Remember that this is a classic triple deformity. I
Yes,
think
sir.
it
Yes,
is
absolutely.
classic,
Yes, sir.
is a classic triple deformity. The history is very significant, and the most important part. Remember, the examiner will ask you the wasting. You will never find this much of wasting in any of the diseases like your TB knee. So there will be gross wasting around the thigh muscles. Most of it is like a skin and bone sort of thing. Okay, and there will be the knees probably in 80 to 90 degree of flexion. Okay, so there will be classic wasting, and also there will be triple deformity of your knee.
Absolutely. And sir, sir, a few points about sir, the bursitis, prepatellar bursitis, intrapatellar bursitis, and you can add sir, the popliteal cyst. A few points, though these are again very rare cases which are given in the exam because they don't.
No. I think they might get the Baker cyst or the
Yes.
The popliteal cyst, because they will be asked only one the pertinent question. That remember that in Baker cyst, in extensal it will be there, but if you flex it, it disappears. But in semi-membranous cyst, it will be same both in flexion and extension. Another one point that you remember, that it is the Baker cyst is the midline one, and the semi-membranous cyst is the medial ones. So from the location also, you have to identify, because they will ask you this pertinent question, how to differentiate from the Baker cyst from the semi-membranous cyst. Okay, so if the swelling disappears in flexion, it is the Baker cyst. If it is the size is same, then it is a semi-membranous cyst. Baker cyst is the midline one, semi-membranous cyst is the medial one. So these are two things that if you answer, the examiner will be happy. And another one is the you ask about the prepatellar or the your housemaid and all this. I think we have all read infrapatellar once. So this I think your classic location will tell you if it is in front of the patella or if it is in front of the tibial tuberosity. Then you understand that this is the classic one, because this is post-traumatic might be, or most of the time in that your housemates or the tibial ones is because of the chronic friction on the kneeling position. Okay. And also there will be some callosity in the front.
Okay, sir. And sir, last but not the least, a little bit something about sir the tumors around the knee joint, like what we get classically. We will be mostly discussing osteochondroma tomorrow in the pediatric uh, session. A little bit around what tumors and what are the things, or what are the little bit of like guidance regarding the tumors around the knee joint, and what again the common mistakes.
I think I deliberately just not touch the tumors once because this is the big topic to see. But we got to remember the classic thing that you have to follow: look, feel, move, measure. So look, what will be? There will be shiny skin. If there is venous prominence and there is wasting, venous prominence is a very important thing. If you see the tumors, okay, if you these aggressive ones. But for the osteochondroma, you will not find this venous prominence or the shiny skin unless it is a big one. Okay. Then for the tumor, the skin is also very important. Sometimes the age is very important because in the age group, in the age is very important because by that way you can more or less understand which group of tumor probably you are facing to. Then in the knee tumor, benign ones, is the most of the time you'll be getting the osteochondroma in the adolescent group. Okay. And if you get an osteochondroma around the knee, I will request all the examinees that don't forget to see, at least just run through your examination from your both the arms, see the back for your any pigmentation, any neurofibroma, or because you know that this is the classic combination of your the Olias disease or the multiple
Mafuchi syndrome.
So remember, the examiner, even if it is a very rare one, probably it is not there, but the examiner will be happy that you have examined and the back you have seen for the pigmentations, you have seen the arms, because if you miss any extra the exostosis on the arm or the scapula, then they will catch you. So remember, you might miss in the scapula or else you can in the arm. And the classic tumors, probably you might be getting either the giant cell tumor or your osteosarcomas. Okay. But as because these are painful, we usually don't put this in the exam case. Even if it is put there, we don't allow the examinee to do a lot of tests because this is really painful for the patient. So if there is shiny skin, your venous prominence, the wasting is there, age is matching, then probably you might take that this might be a tumor case. Okay.
Okay, sir. So I think that should cover our knee examination and the common cases that that the students face in the exam. Sir, any other comments?
I think if the examinees they have attended the last PG course, if they are there, so we have explained every single test with the volunteers over there. So I think that was a great one, and if that has been already been recorded, I think if you can go through that, you will be definitely finding all those things because me and Dr. Devabroto Banerjee were there at the knee faculty. We explained every test over there. And I think you go to the ward and tell your seniors to just check for this common test. Whatever I have told today, this is the common test you should not miss on these ones. So these are the common tests that is asked for. You don't ask for the hyperextension valve or rotation test. You have to see the 4 requisites of the ACL, sac sign, Godfrey sign, posterior drawer, your 0 degree, 30 degree of MCL, patellar mobility, patellar grind, and the J sign and varus and valgus of the knee. If you don't, this is a common Q angle. So these are the common things that are asked. Never the examiner is going to ask you very high-fi things in your examination.
Right,
over
sir.
to,
Thank you.
Over to Shom.
Yeah, I think we're done with the last session. So I think we'll call it a day. And I'd like to thank all our national and state faculty. Shananda Shamanto sir, fantastic presentation. So I know basically this is a PG crash course. So everything has been taught in detail in the PG course. So this is just a small revision for everyone. I hope this was, very helpful. It was very helpful for me because I learned many new things and revised a lot of old things as well. So yeah, I think thank you, sir. I think we'll just take everyone's leave and we'll join tomorrow at 6.
Yes, thank you everybody, and best of luck to all the
Outgoing.
examinees. And, tomorrow I am not there, so I think that tomorrow also you'll be definitely have a great class for the exam. Thank you
Right.
very much for
Right.
giving me the
Thank you,
opportunity
sir.
to be
Thank you,
here.
sir.
Thank you.
Sir. It was a pleasure listening to you.
Thank you.
Okay, I think we'll end the session.
Yeah, sure. And anyone else in the among the participants, like the presenters or anyone want to make any comments or make any associated any points which they want to raise or what they want in the program for tomorrow? If any issue or any special thing which they want to mention, because tomorrow our session will be on this thing, pediatric orthopedics, and we will be having a session on elbow and shoulder examination, followed by our instruments, MRI and
X-rays, MRIs, etc.
etc., which will be like the smaller and I suppose the less hectic part of the exam, I suppose. And then, right. So yeah.
Yeah, I think.
Okay. Sure. Okay.
Just one thing, hello.
Yes.
Yes, sir. Yes, sir.
Please,
Yes, sir.
please. Yeah.
Sir, please, sir. We are waiting for you.
Good evening, yes, sir. Just
Good evening,
I am
sir.
yes. Nice to hear all these things. One thing I would ask, all the participants should make some questions that will make more fruitful, I hope. So I would request all the participants to put forward their doubts so that if we discuss, that will be better. Okay. That's the only thing I'd like to. Thank you.
Right, sir. Thank you, sir. Thank you, sir. We'll note it.
Good night.
Good night. So should we ask our any other the students who have logged in? Should we ask them to give a talk or something like that, or just just mention about the program, what they wanted, or they have any doubts, they can always
They can always text us. They can text on the official YouTube channel. They can comment there. They can comment. This is not.
Thank you, Abhishek and Shom.
Okay.
We have done an excellent job, and
Thank you.
compiled, and we have heard this good lectures and also compilation of the good.
Thank you, sir.
What are the points in favor of the diagnosis? So, in a quick review, what are the different cases and what are the points in favor? You have discussed everything, but it is the part from the students, so to clear the doubt. So student must, as I am also agreeing, Dr. Vera, the student should ask the questions.
Absolutely. We need more active participation from the students.
So is there any doubt? Then otherwise we can end the session.
Yeah, I think we can end the session for tonight.
Absolutely. Thank you, sir.
Okay.
Looking forward to sir listening to you tomorrow, sir.
Thank you.
Shom, I think you can end the session. I think we will again this thing resume tomorrow at around 6.